So what we'd like to do now, or what I'd like to do now, is welcome Professor Steve Martin, Director WCPP, and Steve's going to talk about, Professor Steve's going to talk about alternative models of domiciliary care. This presentation focuses on alternative models of care and examples of this from the UK and the rest of the world, which sounds really interesting. Thank you very much, and over to you, Stephen.
Thank you very much. I'm hoping you can hear me and see me.
Yeah.
Good.
Thanks.
Probably don't want to
see you.
Me, but so thank you very much for the invitation, to especially to Maria and to Lucy for making this possible for us. As Malcolm's very kindly said, my name's Steve Martin. I'm the director of the Wales Centre for Public Policy. We don't especially like our acronym. It sounds a bit like former Soviet Union or something, but anyway, we're colloquially known as WCPP. And I'll explain a little bit more about the organisation and then the project in a minute. But firstly, important to say, apologies from my colleague Laura Bennett, who actually did the work that I'm going to be presenting this afternoon. Laura's had a family bereavement relatively recently. Very sadly, her brother, who she's the primary carer for, has passed away. So I know that she really wanted to be here, but she just doesn't quite feel up to it so shortly after that bereavement. I haven't been closely involved in this work. I supported Laura in it, but she's our health and social care expert. So what I wanted to do was run you through some of the key messages from the report. For those of you who haven't yet seen it, it's published and available for free on our website. I'll give you the address in a short while. And what I'd suggest is that today can be a taster. And if you want to know more, please do download the report or the policy briefing, which is a much shorter document that goes with it. And I know that Laura will be very happy to field questions by email or to have a chat once she's back at work in a week or two's time if you wanted to follow up on anything. But I'm admitting that I'm not at all an expert in this field, so approaching this with a little bit of trepidation and acknowledging up front that I'd probably struggle to answer your detailed questions on any of this, so feel free to follow up with Laura. And it does mean that I'm going to be sticking more closely to the script than I ever normally do, so please forgive me if at times I'm looking down and reading. And I'm going to use the Downing Street method of next slide, please, so just bear with that as well. So could we have the next slide, please? Thanks. So Laura's very organised. She does it more systematically than I would, but this is roughly what we're going to cover over the next 20 minutes or so. So as I said, I'll say a little bit about the centre. I'll then talk about the project that we were asked to take on, how we approached it, what we discovered, and some of the key messages that we're taking away from that, which I hope will be useful to you this afternoon. Next slide, please. So my centre, it consists of about 20 of us. We're based at Cardiff University, but we're not a traditional research centre in that we don't seek to generate primary research ourselves. We've been set up to try and enable public policymakers in Wales and public service leaders and those delivering services to be able to access research evidence, which is often, I know, hidden behind paywalls, written in archaic academic language and presented in peer-reviewed journals, which nobody in the real world reads. So our aim is to make more available the considerable expertise that there is in Welsh universities, but across the UK and further afield as well, by taking what we call a demand-led approach to knowledge mobilisation or evidence use. So we try and find out what sorts of evidence will be useful to you, to Welsh Government ministers, officials, and other public services and public service boards. And then we seek out academics who have already done research in that field, who we think have useful things to say. So we position ourselves between the worlds of policy and practice on the one hand, and academic social science research on the other, and try and facilitate a dialogue between those two. You can find out a lot more about our work on the website if you're inclined to do that. I'm hoping that many of you already signed up to receive our regular news updates and alerts publications. If you're not, please do that if you're interested. It's very easy process to do. The only other thing to say about the centre is that we span all devolved areas of responsibility. So we don't purport at all to be experts in social care or care in the home. But what we do is, it's a bit like the old AA advert, we might not know, but we'll find a woman or a man who does. And a lot of our work is therefore undertaken in collaboration with experts in the field. Next slide, please. Here's the report that I'm going to be speaking about today. As I say, it's on our website. I guess that's just a picture to prove to you it's there, and it's in both languages. Next slide, please. So the background to this was, it was one of the pieces of work which we were asked to undertake for Welsh ministers. In fact, the First Minister himself commissioned this from us. He was interested in ways of pursuing, as you know, what he calls the rebalancing agenda, a concern that, I guess, a concern about whether the market is overly dependent on the private sector, and interested in an exploration of whether there are ways of bringing other kinds of provider in and, quotes unquote, rebalancing the market in that way. That was the question that we were set. We set about that by looking at examples from Wales, from England and other parts of the UK, and then casting our net a bit wider to some international examples, which experts who we spoke with suggested to us might provide interesting insights. Of course, there are always challenges with that approach. What works in Canada or Sweden might well not work here because it's a very different context and set of circumstances. But we tried to gather together what we hoped was some applicable lessons for the challenges which we face here in Wales and the approaches which we're trying to encourage. Next slide, please. And what we did was to undertake an evidence review. This is the royal we all the time. It's actually Laura and another colleague, but bear with me on that. So they looked very carefully at both the academic evidence and the grey literature, the policy literature, work by think tanks and other organisations. Then they had a whole series of conversations with experts, both here in Wales, across the UK and overseas. And out of that identified a series of case studies of approaches to providing care in the home, which they thought might provide useful insights for the First Minister, given the question that he'd set for us. Next slide, please. So firstly, turning to our discussions with experts who knew about Wales, and we spent some considerable time trying to establish a kind of baseline knowledge for ourselves around this. And I don't think there'll be any surprises for those of you on today's event about what we were told. If there were, then please let us know. But everywhere that we've talked about this, people have gone, yeah, that seems a fair summary of kind of this current state of play. So there was a quite widespread concern that the current state of the market was shaky, possibly even unsustainable, so that this was an important issue to be looking at. But nearly everybody who we spoke to said, with all due respect to the First Minister, their primary concern was not about rebalancing, but was about ensuring that the market was able to provide high quality care in response to the likely level of demand over the next few years. So experts started to reframe our questions slightly to focus less on who provides and more on how, whoever the provider is, how can we ensure that there's high quality, person-centered, responsive care in the home available for those who need it and want it. That led us, not surprisingly, into a series of conversations about commissioning, and I'll say some more about that in a minute, but commissioning right at the heart of the answer to that question about how do we produce a sustainable market providing high quality care. And as you would expect, a lot of people talking to us about the importance of the workforce, the need to recruit and retain a high quality workforce, and at the root of that, of course, questions of funding, the ways in which we could enhance funding for social care in general, but care in the home in particular. Next slide, please. And then when we came to look at other countries, it was interesting to find that the experts there and the case studies that we looked at were grappling with very, very similar issues. And of course, that's double-edged. It meant that we didn't find a silver bullet, somebody somewhere in the world who had solve the problem completely and we can just bring them to Wales and tell us how to do it. Be naive to expect that anyway, wouldn't it? But all of the providers who we spoke to and all of the experts who we spoke to in other countries were pursuing ways to provide more personalised, holistic care. Like providers in Wales, there was an emphasis on how do we move to more preventative approaches and how do we join up care provision across health, social care and other services. There was widespread agreement amongst international experts that finding ways to provide greater flexibility and autonomy for the workforce was a really important key to unlocking some of this more personalised, holistic care. And there was hints from some of them, at least, that one of the ways of doing that is to provide more encouragement for smaller providers. And I'll say a little bit more about that in a few minutes too. So what we found was very broad agreement on the challenges facing Wales and some strong echoes of that when we talked about the context and the approaches being taken in other countries. Just checking myself for time and we're doing fine. Next slide, please. So now I'm just going to talk you through, in the report itself, there's a much wider range of examples than we've got time to go into today. As I said, some from Wales, some from England, some from Canada, Sweden, and the Netherlands. And we've tried to present that in a reasonably kind of accessible way. So please don't expect an academic tone, expect something which is written for you and others who are grappling with these issues on a day-to-day basis. The first example that Laura wanted to bring to your attention, had she been here, are wellbeing teams, which I know will be known to many of you. Wellbeing teams is a domiciliary care provider operating across the UK in places like Wigan, Oxfordshire, Thurrock. And it was interesting to us because that approach has tried to adopt some of the principles of the Berkshold model, which has been, as you know, pioneered in the Netherlands, a very person-centered, flexible approach, which actually goes beyond what we would, I think, traditionally think of as care in the home. Wellbeing teams were highlighted to us by a number of experts as an example of what they thought was high quality person-centered care. We're in some senses taking this on trust that we couldn't find a formal evaluation of what wellbeing teams do. I think partly because they were only established in 2016, so they're still a relatively recent phenomenon, but they've been rated as outstanding by the Care Quality Commission and they've won a number of awards. They themselves also report significantly lower levels of staff turnover than many traditional providers of dom care. As I said, they've based themselves on the principles of the Berkshold model, so self-managed teams, a neighbourhood-based approach which seeks to be flexible, to build on community assets and to provide relationship-based care with some degree of autonomy for the teams who are delivering that care. So small neighbourhood-focused teams trying to respond to people's preferences and their carers' preferences around the kind of support that they need. There's a strong emphasis on regaining independence for those who are able to do that and connecting people with community assets. And they've done some things to improve working conditions for staff. For example, staff are salaried for shift work and not paid on the basis of contract time. And their approach to recruitment looks very much at somebody's values as much as their experience. And they're also using technology in ways to support staff and to support the receivers of care in ways that we thought were interesting. So that's all very positive. Of course, we come to the crunch point, which is that it's very difficult to provide that level of care with traditional rates of remuneration. And wellbeing teams have struggled with affordability. It requires investment. It requires a different approach to commissioning. But one of the ways in which they said to us that they've begun to ameliorate that is to expand the notion of what care in the home actually encompasses. For example, they've had district nurses training care workers to carry out some fairly straightforward apparently. It doesn't sound straightforward to me, but administering injections and incorporating elements of social prescribing, for example, into the care package. So wellbeing teams, we think, are an interesting example. Again, they're not the perfect solution, but we think there are some lessons that can be learned from them. Next slide, please. Secondly, Laura wanted to talk a bit about what's happened in Somerset for a number of reasons. Firstly, they were probably the best example we came across of an attempt to support micro enterprises. And secondly, it was presented to us as an example of an approach which is probably particularly suited to rural areas, which may be relatively unattractive to large traditional providers of care. So just to give you the kind of key points of the Somerset approach, if you're not familiar with it, it's very much based on the notion of community catalysts who provide startup support for people who may be very experienced care providers, but probably aren't business women and men, and require a bit of support to set up their own micro enterprise. They've been very successful in that. There are nearly 600 micro providers in the country, and in the county of Somerset, and they provide almost half of the care and support that's given in the community. And Somerset only has one large provider. The majority of the social care provision there, 90%, is provided by very locally based businesses. So this model works by having a contact centre which seeks to find community-based solutions first and foremost, and not as an alternative, but as a kind of a parallel to a formal social work assessment. And they, as I said, they have community connectors who act as local agents, often based in the same village, who are seeking to connect people who are receiving care to meeting points, community cafes. The community connectors often sit in on hospital discharge meetings. So it's a way of supplementing and adding to formal provision by making the most of informal connections and community assets. So again, we don't have a formal external evaluation of this, but Somerset County Council has turned around an £8 million overspend on adult social care in 2015, 2016, and had actually had an underspend within a couple of years. It reports a significant reduction in delayed transfers, discharges from hospital, and outcomes improving, so higher levels of satisfaction for the people receiving the care. I guess the sting in the tail is that a lot of this is made affordable by self-funders and by direct payments. So to start with, we thought this is a really great model which might be useful and applicable, particularly in rural Wales. The funding might be an issue which would need a bit more analysis and explanation. Interesting, and finally, as it says on the slide, we think this is a model which plays to the emphasis on the foundational economy. So providing support to micro enterprises to set up, to establish and to prosper is clearly very much in line with the aspirations that we have here in Wales to invest in and boost the foundational economy. Next slide, please, and our third example. And this is now getting a bit more exotic. So we're going to Quebec in Canada, and we focused on Quebec because it's, along with parts of Italy, it's probably the part of the world that has the most extensive cooperative network provision for care in the home. It dates back to around about 2012, so it's well established, and grew out of actually a concern that most of the large providers were providing exclusively services in English, and the French-speaking community in Quebec felt that it was not being provided for very well. So there's a very specific context and policy driver in Quebec. And what we found was that there'd been a very supportive and proactive legal framework and policy environment and funding support for the development of cooperatives in Canada. And the same pattern emerges in those parts of Italy where you have a very strong third sector cooperative infrastructure providing care in the home. There's a regional development cooperative funded by the Quebec government, whose sole purpose is to develop cooperative enterprises. And there are 60 staff working in that organisation providing support for co-ops who set up. So it's a very different context with a very different legal framework and a heavy investment in promoting cooperative ventures of all kinds, working quite closely in partnership with trades unions, and therefore a different set of arrangements about pay and remuneration as well. So what we concluded from that was that it's possible to have a cooperative-based approach to care in the home, but there would be very significant changes that would need to be made in Wales if we were to provide the kinds of underpinning and infrastructure and support that exist in Quebec. That said, there are a number of examples of small-scale co-ops in England which seem to be flourishing. So it's not that we're saying this model can't possibly work here, but that the Quebec experience is probably not readily transferable. In the report, we talk about Sunshine Care in Rochdale, Caring Support in Croydon, both examples of UK-based cooperatives. So next slide, I can't remember what's on it, but I think we'll skip that one and go to the following one, please. Yeah, so I'm summing up now and channeling Laura as best I can. Our key conclusions, the main messages that we fed back to the First Minister but are now available to everybody in the report and the policy briefing, were firstly that there are fundamental challenges that exist regardless of what model you're embracing. So talk of alternative approaches is, I think, to be encouraged, but without addressing workforce issues and fundamentally funding issues, there isn't a kind of a magic answer. Secondly, as you'd expect, we didn't find one best universal model. We find pros and cons with all of these alternative approaches. And in every case, it's as much about culture and leadership as it is about the type of provider. And I think it's self-evident that there are good and less good providers in every sector. So it's really not about private is good or bad and public is good or bad and third sector is good or bad. It's about having the culture, the leadership, the commissioning processes and the trust-based relationships between commissioners and providers, regardless of what sector those providers come from. And finally, that co-production and person-centered care requires us to find ways of developing contracting processes which allow staff the flexibility and autonomy that they need to tailor the care that they provide to each recipient of that care. When we come to the specific alternative models that we were asked to look at, we've got three big findings really. One is that whilst we might all hope that local authority trading companies would be an answer, and I think in some circles there's an element of kind of wishful thinking invested in local authority trading companies, and it would be very kind of consistent with the Welsh ethos, wouldn't it? What we found based on those that we looked at in England was that some do very well and some have really struggled and got into financial difficulties. So it seems to be less about the model and more about the leadership and management of the organisation. It kind of might say to me, well, yes, Steve, that we would have thought that, but important to say that, I think. Secondly, turning to micro enterprises, the evidence seems to be that they can provide high quality care and, as I've said, make a contribution to the foundation economy. They may be particularly effective in rural areas, but as I flagged up, the evidence from Somerset is that they're quite heavily dependent there anyway on self-funders and direct payments, and to the extent that we don't have the same concentration of those sorts of resources in some of our communities, maybe less easily applicable here. Now, franchise arrangements, we think, do enable small providers to enter the market. The question is how scalable they are once they've done so. So questions about, well, by all means, let's encourage franchise models where they're well managed and so on, but we don't think that they too can provide the capacity on their own, which we need and which we're going to need in the future. So where we arrive at is, I think, arguing that let's look at some of these alternative models, and there are useful lessons we can learn from others in Wales as well as from across the UK and elsewhere. But we really do need to grapple with the fundamental issues around funding, around workforce, and to develop as fast and as best we can partnership models of commissioning, trust-based models of providing care, which, as I've said, provide the flexibility that we need. I know today is about celebration, so I'm finishing on a very positive note. The practice is out there. I think we can learn from it, and it's good that we're looking outwards in that way. And a message which we heard very often was that the pandemic has both enabled providers and commissioners to build on existing good relationships to respond very flexibly. So time and again we heard stories and accounts of really impressive agile responses to the pandemic, and this fieldwork we were doing in actually quite the early stages of the pandemic. And secondly, that in some places where those trust-based relationships weren't as well developed as perhaps one would have hoped already, then the COVID crisis actually was providing an incentive and a need for people to move to a new form of relationship between commissioners and providers. So really hopeful signs actually that in the midst of a terrible crisis and public health emergency, both commissioners and providers were responding very adaptably and in an agile way, which perhaps if we can build on that and sustain it into the future, there's a good kind of foundation there. Thank you. Again, apologies that I'm not Laura, but I hope that that gives you enough of what's in the report to make you think that you want to go and have another look at it if that's something.
Brilliant, Professor. Thank you very much.